Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 566 of our pharmacotherapy series, which majors in sleep disorders. The first case reads, CMB, a 33-year-old woman, is hospitalized after a suicide attempt in which she tried to overdose on sertraline, ibuprofen, and diphenhydramine. Before the suicide attempt, CMB had been sober for 3 years. She is diagnosed with major depression and alcohol substance use disorder. After completing an interview with CMB, you learn she stopped taking fluoxetine 5 months ago due to insomnia. She reports doing well until 3 months ago, where depression symptoms worsened during her divorce. 2 weeks before admission, her outpatient primary care doctor prescribed sertraline for depression and omeprazole for acid reflux. She went on a drinking binge 5 days ago that ended with the suicide attempt. Her target symptoms include early morning awakening, trouble falling asleep, 15-pound weight loss, apathy, social withdrawal, depressed mood, hopelessness, and anhedonia. Medications continued in the hospital include sertraline 100 mg daily and omeprazole 20 mg daily. CMB currently reports feeling restless and sleeping only 3 to 4 hours a night. Compare the clinically significant differences between available hypnotics and to demonstrate how such information can be used to develop a patient-specific treatment plan. What is the best approach to solving CMB's sleep problem? Concomitant conditions and the type of insomnia, difficulty falling asleep, difficulty maintaining sleep, early morning awakening, are assessed simultaneously. Possible causes or contributing factors are identified and treated. The type of insomnia can aid in treatment selection. Cognitive behavioral interventions can be implemented if CMB is willing and able to participate. Factors to consider in the drug selection process include substance abuse history, the need for rapid onset and duration of effect. For example, agents with long-acting metabolites, e.g., flurazepam, may accumulate or cause daytime hangover. If the hypnotic has no hepatic metabolism, it will not be subject to drug interactions with other agents that are hepatically metabolized. Also, if insomnia is chronic and resistant to hypnotic treatment, or if a low abuse potential agent is desired, e.g., for a person with an existing substance use disorder like CMB, trazodone or another sedating antidepressant may be selected. The next question reads, what type of insomnia does CMB have, and how is it different from other types of insomnia? CMB has trouble falling asleep and early morning awakening, and sleep time has decreased to 3 or 4 hours a night. She is diagnosed with major depression, and sleep difficulty is part of the disorder. Generally, initial insomnia and early morning awakening are associated with depression, although difficulty maintaining sleep and next-day fatigue are common as well. CMB is most bothered by trouble falling asleep, early morning awakening, and next-day fatigue. Up to 65% of outpatients with major depression report one or more symptoms of sleep disturbance, whereas 90% of inpatients with depression like CMB report insomnia. The insomnia of depression is likely related to a dysregulation of neurotransmitters, such as serotonin, norepinephrine, and dopamine, in addition to dysregulation of the hypothalamic pituitary axis. All are involved in regulating mood and the sleep-wake cycle. Neurotransmitter activity is modified by the effects of antidepressants on rapid eye movement sleep. Most pro-serotonergic antidepressants suppress rapid eye movement, causing increased rapid eye movement latency and decreased total rapid eye movement time. Indeed, rapid eye movement sleep deprivation can elevate mood. Depressed patients deliberately deprived of rapid eye movement sleep have had a reduction in depressive symptoms. In addition to effects on rapid eye movement, antidepressants redistribute slow-wave sleep to more physiologically natural patterns, with increased intensity in the first half of the night. Sedating antidepressants with serotonin 2, abbreviated as 5-HT2, antagonist properties, such as trazodone and mirtazapine, alleviate insomnia and improve sleep architecture. CMB and the treatment team ask you what factors other than depression, i.e., medications, alcohol, may contribute to CMB's insomnia. How can her sleep problem be solved? We will now focus on treatment. The treatment for CMB's insomnia should begin with patient education. She should be informed that more than 90% of depressed patients have some sleep disturbance, either too little or too much, and her sleep should improve as depressive symptoms improve, in 2 to 8 weeks. Counseling on cognitive behavioral interventions to improve sleep may be appropriate when CMB's depression begins to clear and she is more motivated to improve her sleep hygiene. In the meantime, the potential contribution of sertraline causing restlessness or insomnia should be assessed by confirming the drug is dosed in the early morning to minimize this effect. A sedating antidepressant such as mirtazapine may be preferred unless CMB's history includes a positive response with sertraline that would justify ongoing treatment. CMB also was using alcohol before admission. Alcohol disrupts sleep and can increase arousal when its sedative effects wear off, leading to more fragmented sleep. All patients should be counseled to have their last alcoholic drink at least 3 hours before sleep. CMB should avoid alcohol altogether given her history of abuse. Drug and alcohol withdrawal and the lingering abstinence syndromes often are associated with insomnia, although sometimes hypersomnia is the predominant symptom. What is the evidence for trazodone's use in managing insomnia? What other antidepressants are used in the treatment of insomnia? Discuss the advantages and disadvantages of using sedating antidepressants for the treatment of insomnia in CMB. Prescribing a hypnotic short-term or a sedating antidepressant is recommended for depressed patients with insomnia because a good night's sleep can improve treatment adherence and daytime functioning until antidepressant effects become apparent. All antidepressants, including selective serotonin reuptake inhibitors, such as sertraline, can improve sleep as the depression lifts. However, most antidepressants like selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, e.g., venlafaxine, divenlafaxine, or duloxetine, bupropion, and monoamine oxidase inhibitors can all cause insomnia as well. Analysis of residual symptoms in partially treated depressed patients taking selective serotonin reuptake inhibitors shows continuing insomnia is present in 44%, requiring additional interventions such as trazodone or mirtazapine. Hypnotics that act at benzodiazepine receptors are not recommended for CMB due to her drug use history and recent alcohol abuse. Older non-selective benzodiazepines like temazepam can have a euphoric effect, are cross-tolerant with alcohol, and are likely to be abused by patients with alcohol and substance abuse problems. Abuse, dependence, and withdrawal reactions have been reported with newer GABA receptor alpha-1 subunit selective non-benzodiazepine hypnotics, such as zolpidem, zaleplon, and essoplon. Therefore, neither class of drugs is appropriate for CMB if the clinician determines that sertraline treatment is preferred. Then trazodone may be added to alleviate insomnia. The addition of trazodone to fluoxetine, bupropion, or monoamine oxidase inhibitors decreased time to sleep and increased duration of sleep, but caused intolerable sedation in a few patients who received fluoxetine. Tolerance did not develop to the sedative effects of trazodone in short-term studies, that is less than 6 weeks, used adjunctively for depression. However, decreased benefit with time has been reported. The 5-HT2 antagonist properties of trazodone at low dosages, in addition to its antagonism at histamine 1 and alpha-1 adrenergic receptors, provide the rationale for its efficacy as a sedating agent. Trazodone is not thought to be a highly effective antidepressant medication because most people cannot tolerate an effective dose, that is 300 to 600 mg per day. Because of its sedating properties, low-dose trazodone, that is 50 to 200 mg per day at bedtime, has become a commonly prescribed adjunctive medication to induce sleep while awaiting the onset of another primary antidepressant's effect. Trazodone has a half-life of approximately 6.4 hours in younger adults and 11.6 hours in the elderly. It undergoes hepatic metabolism via CYP2D6 and CYP3A4. Thus, inhibitors of these isoenzymes can increase blood levels and worsen side effects. The most common side effects of trazodone include drowsiness, that is 29.1%, dizziness, that is 21.9%, and dry mouth, that is 17.7%. Cardiac arrhythmias are possible at doses greater than 200 mg per day, as is priapism, a painful prolonged erection that occurs in 1 of 1,000 to 10,000 men. Although priapism is considered rare, it can lead to impotence if untreated. Therefore, men should be counseled about priapism at any dose of trazodone. In the only placebo-controlled trial of trazodone conducted in primary insomnia, investigators compared the hypnotic efficacy of trazodone and zolpidem with placebo in 306 adults, 21 to 65 years of age. Subjects were randomly assigned to receive trazodone 50 mg, zolpidem 10 mg, or placebo nightly for 2 weeks. Sleep parameters were assessed using a subjective sleep questionnaire, which patients completed each morning and at weekly office visits. Trazodone was found to be as effective as zolpidem for the first week of treatment, but during the second week, only zolpidem was more effective than placebo. Tricyclic antidepressants e.g., amitriptyline, doxepin, were used to treat primary insomnia for years based on case reports describing efficacy in doses of 10 to 75 milligrams night. Tricyclic antidepressants, however, increase the risk of cardiovascular problems and anticholinergic side effects in a dose-related manner. Ultra-low-dose doxepin 3 and 6 mg tablets are now available, marketed as Silena, for the treatment of insomnia characterized by difficulties with sleep maintenance. Doxepin is not a controlled substance, so it may be of value in patients with a history of substance abuse. 4 clinical trials conducted in slightly more than 1,000 patients demonstrated ultra-low-dose doxepin's efficacy and safety in both younger adults and the elderly. Doxepin demonstrated improved sleep efficiency during the final third of the night and in the 7th and 8th hours of sleep. Doxepin was well tolerated, with residual sedation and anticholinergic effects no different than placebo. There were no significant effects on next-day alertness, memory, or psychomotor function. Hypnotic efficacy with doxepin was demonstrated for up to 3 months. The primary disadvantage of this brand formulation is its cost. It remains to be seen whether these low-dose studies will prompt increased use of generic doxepin 10 mg, and whether any advantages can be demonstrated in using the branded formulation. For CMB, a tricyclic antidepressant raises additional safety concerns. CMB has a history of substance abuse and prior suicide attempts. Both are risk factors for future suicide attempts. Tricyclic antidepressants are more toxic in overdose when compared with trazodone, and there are multiple reports of tricyclic antidepressant plasma levels increasing to toxic levels when administered in combination with CYP452D6 inhibitors. Switching to mirtazapine as an antidepressant that offers more sedation is a reasonable consideration for CMB if CMB has a partial but significant response to sertraline at maximal tolerated doses and good tolerability except for insomnia at 4 weeks. Mirtazapine can be added to facilitate remission. Mirtazapine has 5-HT2 antagonist and antihistamine effects, which impart sedation, and it is safer than tricyclic antidepressants in overdose. Mirtazapine is not associated with priapism, but it can cause weight gain. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 567.